I'm Dr. Stephanie Wilson. I'm a radiologist from Canada, and I'm going to speak to you this morning about contrast-enhanced ultrasound. So microbubble contrast agents, which are used for contrast-enhanced ultrasound, were approved for use in radiology in 2002. And the approval indication for these microbubbles is for characterization of liver masses. And so that remains our major objective in using them. However, microbubble contrast agents also allow us to have blood flow information about any portion of the body that we can see with ultrasound, and this is unique to them. And previously, when we wanted this kind of blood flow information at the tissue perfusion level, we had to do either a contrast-enhanced CT or MR scan. So consequently, we do use them for looking at the liver, but we've also expanded the indications broadly. And the great advantages we have in using these microbubbles include that there is no toxicity to the kidney, so this is unique to these microbubbles. The microbubbles also can be visualized dynamically, so neither CT or MR, which take a snapshot in time, allow us to see the movement of the contrast agent through the body. And so these dynamic capabilities allow us to show exquisite vessel morphology, for example, within a liver tumor. And they allow us to do things that otherwise would not be available to us. In addition to this lack of toxicity, we also, of course, have to remember that many of the studies that we perform are on young patients, on female patients, and even on children. And of course, we don't want to expose them unnecessarily to ionizing radiation. And so if we look at North America in particular, CT scan has been the workhorse for doing many contrast examinations. And so we have replaced large numbers of these examinations in our institution with contrast-enhanced ultrasound.
And can you explain why that's important? For example, a cumulative exposure over a person's lifetime?
Yeah. So radiation risk is recognized both by the lay public and by professionals as an increasing and very significant healthcare risk. And so the biggest exposure that we have as individuals living on this planet is in fact not from things like riding in a plane to Hong Kong or these scanners that we encounter at the airport. Those are the things that people are worried about. But in actual fact, the exposure that we get from common medical imaging tests is the significant exposure that patients do in fact encounter. And so we know that children, for example, women in childbearing years, that all of these are times when we want to avoid that radiation, but it's even a bigger problem than that. And so if we take populations, one that I'm very interested in are patients that have Crohn's disease or inflammatory bowel disease. So this cohort of patients are actually the group of patients, the single group of patients in the whole world that are identified that have the biggest risk of cumulative exposure to radiation, in that they have a CT scan when they're diagnosed. They have another CT scan every time they have a clinical flare. They have a CT scan every time the doctor wonders whether they're responding to their therapy. And so this does not amount to 3 or 4 CT scans. This amounts to 10 or 20 or even 30 CT scans over a couple of decades. And so this kind of cohort of patients are recognized as patients who genuinely require a less invasive technique for monitoring their disease. And if we take elderly patients, for example, who have heart disease or have stroke problems or who have cancer, in them there's no question that the radiation risk is not as great. However, I will tell you that without hesitation that the masses of young people who have a CT scan every time there is something wrong with their abdomen really adds up, and they're a significant focus of people who do what I do as part of their clinical practice.
Excellent. And do you have any particular patients who, without naming names of course, you remember a young girl who came to you and she had already had so many CTs and there's the cumulative risk?
Well, actually, the ultrasound is a very special test, and patients who come for example, to a facility such as mine. So I work in a tertiary referral area. And so for patients who have something wrong, ultrasound provides them a special test as compared to other imaging tests, in that there's a physician present when they're having their examination done. And so it's a very interactive test for them. And so patients generally have a very high subjective feeling of value when they have an ultrasound examination performed, when it's done with contrast and with all the special things. So they have definitely a feeling of value, the value added, and in that they have the benefit to interact with us. And so certainly, again, coming back to the inflammatory bowel population, they're all very happy to come back for ultrasound. It's a painless test, it's a very easy test, and patients also they're very excited to see their disease at one point in time, and then to see their disease, unfortunately it can get worse, but it can also get better, and so then they can appreciate that. And the other populations that come back to see us very frequently is patients that have risk of liver cancer. So we can identify the risk populations. And so those patients, for example, they come for liver monitoring to look for liver tumors every 6 months. And this goes on for the duration of their life. And so, of course, if you're doing that with CT scan, it's untenable that you can scan them with CT. But in America, there are patients who do have CT as their surveillance technique. And so to replace that with contrast ultrasound is also, patients are just happy to come for ultrasound, and then any imaging that we do in addition is with contrast ultrasound, and they don't need to go for a CT or MR unless we have a heightened suspicion that that would be helpful as well.
How is it that contrast ultrasound picks up a liver tumor?
Well, ultrasound picks up the tumors, and contrast ultrasound characterizes the lesion. So in other words, we do the standard ultrasound looking for the tumor. We can see the tumor as a variation in the echo pattern in the liver. And then when we identify the tumor, then we perform contrast ultrasound to characterize the tumor or the lesion.
Characterize it meaning?
When you're imaging the liver, there's basically two questions that you have in terms of focal liver disease. So the first question is there a tumor? And so that's a question of detection. So you're answering the question, is it there? And so then once you know it's there, so you could have found it in various ways. You could have felt it. For example, if you were doing an operation on the patient, you can feel it through the patient's skin. You could have seen it on any imaging test, ultrasound, CT, or MR scan. So once you know that the lesion is there, then the next question is, what is it? And so the answer to that question, what is it, that is characterization. And so the way we characterize is by blood flow information. And so both CT and MR and ultrasound all look at the enhancement. So that means you have a tumor, you inject a contrast agent, and then you look at how much it enhances. And so we look at two different time frames predominantly, the arterial phase right after we inject the contrast, and then slightly later in the portal venous phase. And so CT, MR, and ultrasound all show that enhancement in the same way. In other words, it gets brighter when it enhances, and then it becomes darker as the contrast goes away. And so our abilities to do that are quite identical, ultrasound, CT, and MR. However, ultrasound has this magnificent additional value in that it has this dynamic real-time quality, so that when you inject the microbubbles, you could actually watch them, and then through a tracking technique that only ultrasound has, we can actually show the blood vessels in the tumor. So we have that additional dynamic component. So that's one of the really special aspects of ultrasound. And then beyond what we're speaking about here, and more sophisticated patients wouldn't understand this as much, but microbubble contrast agents, when they travel in our body, stay only inside our blood vessels. And that's a very special thing as well when we're imaging them, in that we know that anywhere we see them, that when we're looking for them, we know that they're always within the blood vessels. Whereas CT and MR contrast agents both enter into the blood vessels, and then when they come to a cancer, the contrast agent can pass through the wall of the blood vessel into the tissue. So then when you're imaging it, in actual fact, you're not looking at the blood vessels, you're looking at the contrast that's in the blood vessels, and the contrast that's passed through the blood vessel wall into the tissue. So that interstitial contrast agent actually makes it so that when you're trying to monitor what's happening to the blood vessels, they're inadequate to do that task. And so one of the special talks, there will be someone speaking about it today, I believe, but last year there was talks on this for sure. But one of the new therapies that we have for treating cancer is to use what are called antivascular therapies. So instead of being chemotherapy agents, which are cytotoxic, like in other words, when you take chemotherapy, it kills rapidly proliferating cells. And for some cancers that has been very effective, but across the board, as you know, there are many cancers which are not, they don't respond to chemotherapy. So a more recent, very popular, hot topic today is the use of these antivascular agents. So when they're administered, they actually selectively kill rapidly proliferating blood vessels. So that's blood vessels that are inside cancers. But so then when you monitor the response to an antivascular agent, you have to look at, there were so many blood vessels when we started and how many blood vessels are there now when we're doing our monitoring test. And so you have to have a purely vascular contrast agent to monitor that, because you have to know whether there's blood vessels or whether they're gone. And so you can't use a contrast agent that passes the blood vessel wall into the tissue, because then you're not measuring the correct thing. So ultrasound contrast agents have a tremendous potential to be the monitoring technique for looking at these cancers. And so there are people here in attendance at the meeting who really believe that that will perhaps be the future of microbubbles finally being approved for imaging in the United States, is the recognition by, hopefully by the FDA, that they're the required modality and contrast agent type, you know, for doing this. But that's beyond the clinical scope of disease.
Right. Do you have a sense that there's worldwide acceptance of the use of contrast ultrasound for imaging all of the body?
Like for diagnostic imaging uses, well, there's no question that in Europe and in Asia and in parts of Canada, we do use it tremendously more. And the fact that there's no approval indication in the United States has obviously held the American population back. This is a very, very, very interesting question. And the situation basically is that you have to look at many facets to understand why we do things as we do. And so, as my husband always says to me, money is at the root of all evil. But money is the answer, really. And so remuneration practices dictate to some extent what we do as clinicians and even in institutions. And so if you remunerate CT and MR scan at a hugely greater rate than ultrasound, clinicians will prefer to do MR and CT because they generate a bigger income. So remuneration is definitely an issue, and then the costs in other ways though are favorable to ultrasound. In other words, a CT scanner and an MR scanner cost more than an ultrasound scanner. So those things kind of balance to some extent, but nonetheless, the money that goes into our pocket is from what's actually paid as a fee code.
Could you give an example of how much the big
differences?
scanners cost? Yeah, you did that last year.
Well, an ultrasound scanner you can buy for a few $100,000, a CT scanner for probably $1 million, and an MR for $3 million. So there's a big difference. And we get paid, we might get paid, it's very variable even between Canada and the United States. But an ultrasound might be reimbursed at something like $50, $100, whereas a CT and an MR for interpretation might be 10 times that. And the problem with that is that ultrasound, in fact, this is the negative aspect of the ultrasound. Ultrasound is labor intensive. And so, for example, if I were going to read a CT or an MR scan, a technologist would already have done everything in terms of taking the pictures, even doing a lot of the reformatting and multiplanar imaging. A lot of that is done somewhere else. And so then the physician's role, to a large extent, is at a computer console where they're going to read images. and to do ultrasound in a fashion how I do ultrasound. This, of course, is not how it's always done. But I mean, I'm up and down in every room, hands-on every patient that I scan. And then to actually do the really high quality work like that we do with contrast and with all the other things that we do, we spend a long, long time doing our scans. And so a lot of radiology departments don't want to incorporate that kind of labor-intensive work into their departments. And so these are reality situations. Like, I mean, I deal with this every day. You know, the question of whether or not this is a good thing to do or not. And many radiologists think it's not. Do I think it's a good idea? I love it. So what can I say?
Is there anything else that you think should be said?
Well, you'll have to edit this down like crazy. It's all quick. No, you know, in my own practice, you have no idea. We're so busy. We're booked months out. So I do a GI practice. So I do liver imaging and GI imaging predominantly, but also gynecology. And the varied uses for ultrasound contrast agents are they're unmeasurable. We just do so many different things, and more and more and more constantly. And they're excellent. The liver is what we do the most of, but we do many kidney masses. They're sensational, particularly for cystic renal cell carcinoma, for monitoring aortic stent grafts, patients that have vascular disease. They don't always have their aortas operated on. They have a graft inserted. When you have a graft inserted, again, you have to have, at the very least, you have to have annual surveillance. That annual surveillance in North America is done with CT scan. Every year they have another CT scan to monitor. Now, the patients who have the aortic graft insertion are not children by any means. They're 50 years plus. Most of them, in fact, would be 60 years plus. So you could argue that the radiation that they have is not so important. However, because they have vascular disease, these patients also have renal compromise. Their renal function deteriorates because of their vascular disease. And so to do a CT scan with contrast agents each time is potentially nephrotoxic to their kidneys. So those things are important as well. And so certainly, and for children, that's an additional situation. So in both my former and my current life, I do not work in a pediatric hospital. However, I've tried endlessly for the last decade to have the pediatric people do a study to introduce microbubble contrast agent use in children. And I'm totally confident there's no risk to children any different than there is a risk for an adult. And it's merely a question of doing the studies to show this. And so for children, like with tumors or children with inflammatory bowel disease, there's just no question that to use microbubbles as compared to using a CT scan to image them the value is clear. But the tests haven't been done yet.